The patient is in labor, with contractions approximately every 2 minutes. Cervix is fully dilated at 10 centimeters and has been for 3 hours. The membranes were found to be ruptured upon vaginal examination. The fetus is in vertex presentation, at the +3 station, with its head in left occiput anterior position. With the next contraction, the fetus rotates to the occiput anterior position, but remains at the +3 station. Air tap next to continue. In spite of contractions, the fetus is not descending. The position of the fetal head is correctly assessed. Upon examination, the fetal head fits through the mother's pelvis, ruling out cephalopelvic disproportion. A careful assessment of the clinical situation suggests that instrumental delivery may result in safe and successful vaginal delivery. Choice of delivery instrument depends on the expertise of the operator. The next 2 chapters illustrate vacuum delivery and forceps delivery of the fetus. Air tap next to continue. A vacuum extractor may have a soft or a rigid cup. This instrument is used solely for traction of the fetus. Instrument choice and techniques depend on the skill and expertise of the operator. Placement of the cup over a fontanelle should always be avoided. The cup should be placed over the flexion point, which is about 3 centimeters anterior from the occipital fontanelle, on the sagittal suture. This maximizes traction, minimizes cup detachment, and flexes the fetal head, while preventing it from twisting. To avoid possible complications resulting from vacuum extraction, it is generally recommended to follow the ensuing guidelines. Please note that those are relative to healthcare facility policies and procedures. The number of cup detachments should be limited to at most 3. The vacuum should be applied on the fetal head, for a period lasting between 20 and 30 minutes. A traction force of at most 11.5 kilograms, equivalent to 450 millimeters of mercury, applied on the fetal head, is often enough to conduct a successful delivery. Applying more force may or may not lead to complications, notably, scalp wounds and cephalohematomas. Traction should be intermittent. The operator should let the fetal head recede between contractions, as in spontaneous labor. Exceptions apply, as when delivery is urgently indicated to prevent undue head compression. Air tap next to continue. There are many kinds of delivery forceps. Most are used for both traction and rotation of the fetus. Instrument choice and techniques depend on the skill and expertise of the operator. It is important to note that the inability to lock the forceps properly is an indication of incorrect application. Once the forceps have been correctly placed, apply traction to initiate delivery. Traction should be intermittent. The operator should let the fetal head recede between contractions, as in spontaneous labor. Exceptions apply, as when delivery is urgently indicated to prevent undue head compression. Air tap next to continue. The fetus is now able to descend unaided. Deliver the anterior and posterior fetal shoulders and the fetal body. Once the baby has been delivered, follow hospital recommendations for post-delivery care and complete necessary documentation.